Hi, I'm Michael Battelle from the Fatty Liver Alliance, and I'm here today with Dr. Manal Abdelmalek. She's a hepatologist and professor of medicine at Duke University and the director of the Non-Alcoholic Fatty Liver Disease Research Program at Duke University. And you have a beautiful background behind you.
Oh, thank you.
Thank you so much for joining me today. And I guess we can jump right in. And I want to start by asking you a question about fatty liver in general in the population. And so there's all of these estimates saying that there's about 25%, probably more even, of the population having fatty liver disease. So in North America alone, that's almost 10 million people. How are we ever going to reach that population and how are they going to find out if they even have fatty liver disease?
Right. This is a very daunting issue. We have almost a third of the US population having fatty liver disease. And it's all going to boil down to education, education, education. We have so much to do to increase awareness of non-alcoholic fatty liver disease, but it's not so much the fat that increases risk. It's really empowering our primary care physicians, our endocrinologists with the right tools that in this vast population of patients, we can really cherry pick out those who are at risk. And it's important for our patients to recognize that if you are someone with a family history of cirrhosis, irrespective of how or what was presumed to cause that cirrhosis, you have diabetes, you have been told you have elevated liver enzymes or a fatty appearing liver on an ultrasound, or certainly if you're over the age of 45 or 50, that you should be inquisitive and you should ask, do I have fatty liver disease? Could I be at risk for advanced hepatic fibrosis, liver scarring from fatty liver disease? Because it's those patients who have scarring in the liver that are at increased risk for an outcome. And those are the ones that we first and foremost need to find.
So can you talk a little bit about the association of more advanced liver disease with the metabolic impacts, metabolic syndrome, for example?
Well, fatty liver disease is intimately associated with the metabolic syndrome. It occurs in patients who are overweight or obese, predominantly so. And in fact, those that are lean, that have a body mass index of under 25, only account for about 10% of my patients with fatty liver disease. So the overwhelming majority of patients with fatty liver disease are overweight or obese. It's also intimately associated with complications of the metabolic syndrome. So, patients who are increased risk for having fatty liver disease tend to have impairments in blood sugar control, high cholesterol, high LDL cholesterol, bad cholesterol, low HDL, low good cholesterol, and carry their weight such that they have more truncal central obesity. Um, they're also at increased risk for diabetes, and diabetes incurs a much higher risk for hepatic fibrosis. And patients with fatty liver disease are also at risk for cardiovascular disease. We tend to say three or more risk factors of metabolic syndrome and or the presence of diabetes would increase risk for somebody to potentially have hepatic fibrosis in the setting of NAFLD or NASH, which is the intermediate stage of fatty liver disease with inflammation.
Okay, so if patients are aware that they have a high BMI, what probably 30 or more, and maybe they have diabetes, so they have more than one, as you said, more than one factor, or hyperlipidemia also, and most patients are pretty aware that they have some of these disorders. Do they need to go to their family practice physician and say, "I'd like you to screen me for fatty liver disease and more importantly, more advanced risks for liver disease?"
Well, I think the awareness is step one, and hopefully anybody with obesity and metabolic syndrome certainly is getting annual health checks. And in the context of that standard of care assessments, it's important to evaluate what your metabolic risks are and whether those are under good control, strive towards diet and exercise, and in the same manner that we are assessing what your cholesterol profile is, what your blood sugar is, it's not unreasonable that liver enzymes be evaluated in the same context with blood testing, and certainly if elevated, warrant further evaluation. I don't want everybody inundating all their primary care physicians because this is a condition which spans decades. And so heightened awareness and the opportunity to engage with your doctor at your next health check is important, such that it's also on your physician's radar screen that, hey, maybe I shouldn't ignore those elevated liver enzymes. This could be fatty liver disease. And if there's enough risk, that maybe an abdominal ultrasound could be performed. And beyond that, if there's evidence of risk, particularly in those with elevated liver enzymes, then a risk assessment for fibrosis can be done. That can be done using risk scores. It could be done using non-invasive markers, whether it be with a blood test or even with stiffness measures of the liver, what we call transient elastography.
Thank you for that. And I'm wondering too, just following up on that, are there things that organizations like the Fatty Liver Alliance can do to help educate family practice physicians? Is it about letting them know about, the tools that are available and what they should be looking for? Because like you said, they definitely cannot refer every patient to a liver specialist, right? That's not going to happen.
Um, I think for family practitioners, we are, as a subspecialty or discipline, are striving very hard to develop algorithms and tools that can be at the disposal of our primary care physicians, and to broadly educate on bedside approaches for which a physician could stratify risk. That could be doing a simple calculation, such as what we call fibrosis four score. And in some areas, there is accessibility to a FibroScan or transient elastography. So before we can ask primary care physicians to uh, search for those with advanced hepatic fibrosis in this very, very large population of patients, I think we first need to empower them with the data. We need to empower them with the appropriate tools by which to do so without encumbering excessive testing. So those tools have to be sensitive enough and specific enough, and to validate those approaches more broadly, such that we can have a sound approach to doing population screening.
When you're looking at treatment, there are no pharmacological approaches that have been approved in North America. And so I think physicians at this point are looking at weight loss 7 to 10%, right? As a starting point. Is that what you're recommending to patients now when you see them?
Yeah, I recommend several things to patients when I see them. And it is true that there is currently no approved therapy for the treatment of non-alcoholic steatohepatitis. However, the data with regards to effective lifestyle modification that results in uh, weight loss of anywhere between 5 to 10%, the higher the better, and particularly if it's sustained, is better than any therapy currently tested for the treatment of NASH. The challenge for our patients is doing just that, effectively losing weight and keeping it off. Certainly been a challenge for me over my lifetime too. So I am sensitive to that. And yet at the same time, there are many other factors besides weight alone that play a role here. Dietary factors, um, sleep factors, and sometimes even the severity of the underlying metabolic syndrome. So, as I counsel my patients, I advise them with regards to approaches to diet and exercise. I will refer them to a nutritionist to help empower them with the tools, or even an exercise physiologist that can help them develop an approach to exercise such that they enjoy it, are able to adapt it into their lifestyle, and 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 that they approach exercise in a manner that they are effective. Many of my patients have joints issues, so weight bearing exercise may not be possible, and they just give up. However, what about non-weight bearing exercise? So we can tailor these approaches in a way that can be adapted and sustained. I also tell my patients that our uh, it doesn't really matter what you do. The sedentary lifestyle is what we need to move away from. So you can participate in aerobic exercise, you can participate in resistance exercise. They're both effective. So just moving, doing anything is better than doing nothing. I counsel them with regards to their dietary composition. So they seem to appreciate when I say anything that comes out of a box, a bag, a bottle, or a can is not the approach to eating. Packaged and processed foods tend to be enriched with hydrogenated fats as well as excess sugar. And the two uh, uh, dietary variables that I strive to improve is excess consumption of sweetened beverages, uh, particularly fructose sweetened beverages, um, and uh, and excess red meat and fats. So fried food, excess red meat consumption. And I really encourage coffee consumption. There's some data that suggests that it improves not only metabolic syndrome, but can decrease risk for fibrosis and liver cancer. So it appears that coffee consumption is good. And then we drill down to each and every metabolic risk factor that they have. So if you're diabetic, I strive to improve blood sugar. If there's high cholesterol, I will use a statin therapy to improve the cholesterol and decrease cardiovascular risk. And interestingly, many of my patients have obstructive sleep apnea. And there's a lot of literature that obstructive sleep apnea, if left untreated, can not only worsen metabolic syndrome, but be a culprit to the inability to effectively lose weight or the increased risk of gaining weight, and can also increase cardiovascular risk. And we know that our patients with fatty liver disease are at increased risk for cardiovascular related outcomes across the entire spectrum of the disease, even more so than liver related outcomes. So I work on all of that in the absence of an approved therapy, and it it is it enriching and encouraging that when we come at the treatment of fatty liver disease using standard of care approaches, even we can improve liver enzymes and improve liver fat.
Yeah, you said something incredibly important too. Maybe we could elaborate on that a little bit, that this is a multidisciplinary approach, and every patient is going to have to be treated individually with a tailored approach because we're all different.
That's exactly right. I mean, we are all different, and for some patients, their their underlying risk factor for fatty liver disease um, could be could be metabolic, such as diabetes, and I see others who have hyperlipidemia, no diabetes, and I see other patients who have other endocrinopathies like polycystic ovarian syndrome or thyroid disease. And there are other patients who may be at increased risk both for metabolic fatty liver disease and even social alcohol consumption. So each patient really does need a tailored approach to care and management.
And hopefully we'll be able to help get that information out to physicians as a larger, broader global team, because it's really important for people to understand that different specialties are going to offer different bits of information to the patient that they're going to use, right? And
Right.
as I said before, the liver physicians do not, the specialists do not want to be the ones handling every single patient. And you also touched upon the nutritionist side, and I have heard that the Mediterranean diet is something that's being talked about a lot as well.
Yeah, I encourage the Mediterranean diet. It's one I recommend to my patients. And a diet like that really does strive to more a farm to table a dietary approach. Fresh fruits, fresh vegetables, grilled meats, higher in protein, lower in saturated fats, and really lower in industrialized sugars. So I think the Mediterranean style diet is achieved, but ultimately it's all about energy balance and calories. So excess energy intake really needs to be balanced with energy expenditure. So excess energy that's taken in that isn't expended will wind up being stored in the form of fat.
This is an interesting point. Now, since COVID started, and I don't have the data, so this is anecdotal, but it seems that the average weight of people is going up because they've been around at home more. So I even heard something about the airlines are going to start weighing people. I don't know, but so there's a possibility that fatty liver disease and more progressive disease will be getting worse based on the last year or so. Maybe can you talk about that? Is that true?
Yeah, this is a phenomenon I have seen also in my clinical practice. I started calling it the COVID-10 because on average my patients were gaining approximately 10 pounds, and the longer uh, this pandemic has dragged on, I think we can comfortably call it the COVID-19 because now patients are approaching almost 19 pounds of weight. But this is no joke. I think this pandemic has resulted in social isolation and sedentary lifestyles and concomitant comorbidities that we weren't seeing before that could further perpetuate obesity, depression, anxiety, um, and and frankly, many of us are home more often, and now I have taken pleasure in while we are potentially doing more home cooked meals, uh, there is less physical activity, and with that, potentially more intake. And so it is a general theme that weight has increased with the COVID-19 pandemic. And it is also a general theme that through this pandemic, we are seeing an increase in alcohol intake, which is a cofactor to non-alcoholic fatty liver disease in increasing risk not only of fatty inflammation, steatohepatitis, but fibrosis progression. And so um, we have to be mindful of the impact of COVID-19 on these factors and cofactors as we look upon NAFLD and NASH.
There was a challenge, I would say, with the eating habits in general, fast foods in communities. And I wanted to ask you if you believe, and again, I haven't seen data on this, so maybe it's your opinion unless you've seen something too, but there is an association between obesity and socioeconomic status, at least from the female perspective, I think, and what I've read recently, more than the male even. But would you say that that would also correlate to fatty liver disease and more advanced disease as well? Would it have to do with the socioeconomic status as well?
Yeah, I've reflected on this question, and it isn't true in part, um, but not in full. In westernized and industrialized societies, the prevalence of fatty liver disease seems to transcend socioeconomic status. Um, and we see this independent of income or income strata. We have more abundance to food in general in developed countries. Where this principle holds true is the lowest prevalence of fatty liver disease that we see globally occurs in Africa, where in fact there may be more scarcity of food and certainly in industrialized food. And so there is in part uh, some element of socioeconomic status because we see that in global prevalence trends. But within developed societies, that seems to narrow a little bit. And I think it's just irrespective of socioeconomic status, we have access to uh, more abundance of food and more abundance of the bad types of food. It's very hard in even underserved communities and for patient for my patients to get access to fresh fruits and vegetables. So while they may be in lower socioeconomic strata, we see complications of obesity and diabetes and even fatty liver disease in Hispanic ethnicities, Latino, African Americans. But beyond that, there is an increasing an interesting phenomena that there are likely genetic variants for your risk, independent of socioeconomic status, to develop bad NASH and fibrosis. So, patients who are at increased risk for bad NASH and fibrosis tend to be more Caucasian, and African Americans seem to be somewhat protected from end organ injury for advanced hepatic fibrosis, and that in part may be genetic. So there's no easy answer to this question, but I don't believe that socioeconomic status is a be all end all given the complexity of dietary factors and genetic factors as well.
I just have one last question. I wanted to ask you if you believe the the estimates that say what I started our conversation with today, the 25% to have fatty liver disease and roughly 20% maybe progressing to NASH. Uh, do you think it's more than that?
Um, I think that the trends have been steadily increasing with time. Um, and and the trends have paralleled the rise in both obesity and diabetes. Initially when I first reported the first case, and I was a student at the time, this was a condition that nobody had heard about, and nobody wanted to believe it could occur in the absence of alcohol, and that was only within the past 20-25 years. And it was rarely seen and rarely heard. And as the past decade or two have increased, the trends and the prevalence of fatty liver disease have also increased from 15 to 20 to 25 to 30. And unless we do something as a society to halt this rise of um, cofactors that fuel this epidemic of fatty liver disease, if we don't change the trajectory of weight gain, if we don't change the trajectory of risk factors that contribute to the acquisition of diabetes, to your point, yes, I believe that the prevalence of fatty liver disease is likely higher than projected because, in fact, it's a silent condition and many patients may have it, fatty liver disease, and not even recognize it. So the prevalence data only reports out what we know, and it may be the peak of the iceberg, if you will, but it doesn't drill down to what we don't know. And given the prevalence of this disease, it would be hard to fathom that everybody has had access to even recognizing whether they have it. So the trends may approach 30 to 35% and have reported to be so in out of case studies out of Texas and other states for which the obesity epidemic is higher.
I just saw one recently that was published talking about that exact case. So
Right.
that's what I was asking too. Thank you so much for sharing an incredible amount of information in a little bit of time, and really appreciate it. We'll make sure that a lot of people get a chance to hear what you have to say too. Thank you.
Absolutely. Thank you for the invitation to speak.
Thanks.
Thank you. Bye.